Greetings, everyone. I'm Jason Blackwell, Director of Brand Experience and Public Affairs for the Spondylitis Association of America. On behalf of us all, we'd like to extend a warm welcome to the Health Equity Symposium, the Global and Intersectional Experience of Pain, presented by SAA in partnership with the National Pain Advocacy Center. We are thrilled to have you join us today as we embark on a journey to increase awareness of critical challenges surrounding pain and care, particularly for children, older adults, women, and communities of colors. Hopefully, by fostering an inclusive dialogue and sharing insights, we can advance our collective understanding and work towards ensuring that everyone receives the pain care and support they deserve. So our esteemed panel of experts today are Kate Nicholson, JD, Executive Director of Impact, National Pain Advocacy Center, Dr. Tamara A. Baker, PhD, Professor, University of North Carolina, Chapel Hill School of Medicine, Department of Psychiatry, Dr. Samina Ali, MD, FRCPC, Professor, Pediatrics and Emergency Medicine, Research Director, Pediatric Emergency Medicine, University of Alberta, and Monica Malampali, PhD, Master of Science, Principal and Founder, Institute for Women's Health Strategies, Executive Director of the Alliance of Sleep Apnea Partners, otherwise known as ASAP. Welcome to all of you. So I'd like to share a few housekeeping notes for today's symposium. This session is being recorded. If you have any questions, please submit them in the Q&A panel. We will try to address as many of them as possible at the conclusion of the final presentation. Please make sure that they are related to today's discussions. Lastly, please note that the content and information that is being shared is for information and educational purposes and in no way is meant to be construed as medical advice or an endorsement of any specific treatment plan, service, or individual. And now, without further ado, I am pleased to kick off today's symposium with our first speaker, Kate Nicholson.
So I am delighted to be here today for this discussion of health equity, which is brought to you, as Jason mentioned, jointly by the Spondylitis Association and the National Pain Advocacy Center. This topic is featured during Black History Month because Black Americans are systematically undertreated for pain. Several studies show that providers often rate the pain of Black Americans as being less severe than that of their white counterparts, and also prescribe them less pain medication. But inequities and disparities affect many groups and impact people at the intersection of multiple identities. So I'm going to begin by offering some definitions and a little bit of framing, and then turn things over to my colleagues, all of whom are trusted advisors at NPAC, for a deeper dive. So again, my name is Kate Nicholson. I am the Executive Director of the National Pain Advocacy Center, which is a nonprofit organization that advocates for the health and human rights of people living with pain. NPAC focuses on policy advocacy and systems level change. My professional background, I spent most of my career as a health-related civil rights lawyer, spending 18 months as a disability rights lawyer in the U.S. Department of Justice, 18 years, excuse me, as a disability rights lawyer for the U.S. Department of Justice, and I am a person with lived experience of pain. As I mentioned, NPAC has a rights and equity focus. We envision a world in which pain is treated equitably and effectively, so that everyone living in pain has the opportunity to live a full and productive life. So again, I want to start with a few definitions. We're here to talk about health equity today. What exactly does that mean? Well, it's pretty simple. It basically refers to creating the optimal circumstances in which everyone has the best health possible. It's important to recognize that equity and equality, though, are not the same thing. Equality refers to treating everyone exactly the same way, regardless of their circumstances. But equity may involve treating people differently so that everyone can get to that same playing level or have that optimal opportunity to thrive. A couple more definitions, terms you're likely to hear folks talking about today. Disparities refer to avoidable differences in health status among groups. Inequities are also avoidable, but in addition to that, they're unjust. Unjust differences in the health status and distribution of resources. And finally, social determinants of health simply refers to all of the non-medical factors that affect people's health outcomes, where they're born, where they live, where they work, and the social and economic and political forces surrounding their lives. So all of the major public health policies on pain recognize that in pain, there are significant biases, disparities, inequities in terms of who receives treatment and how people fare. This is true in terms of the Institute of Medicine report, the National Pain Strategy, or the more recent Pain Management Best Practices Interagency Task Force report. But they tend to look at these problems in terms of unitary categories. So they focus on race or disability or language proficiency or age or gender identity. The problem with that is that people aren't unitary. Most people aren't Black or female or disabled. Most of us exist at the intersection of many different identities. So I want to start our conversation by talking a little bit about this idea of intersectionality. And I know it's been in the news a lot, but it's actually a pretty old concept, and it comes from my field, from the law. A law professor named Kimberly Crenshaw came up with the term way back in 1989. And she was responding to a series of cases that came down involving race and sex discrimination. Now, just to back up for a second, Monica Malampalli is going to talk about the difference between gender and sex as it relates to pain. I want to just say that the law or the legal category of sex discrimination is a little different. It's a broader category that considers gender, sex, gender identity, and sexual orientation. All of those sort of come into the idea of sex discrimination in the law. So to give you a sense of what happened in these cases, this is sort of a hypothetical that combines them. But basically, there was a company that had never hired a Black woman. There was no dispute that they'd never hired a Black woman. They hired Black men, mostly for maintenance jobs, and they hired white women, mostly for secretarial jobs. And a Black woman sued for both race and sex discrimination. And the court found that there was neither in her case. Because the company hired Black men, the court said, there's no race discrimination here. And because the company hired white women, the court said, there's no gender discrimination or sex discrimination here. And this obviously troubled Crenshaw. And so she wanted to come up with a really simple way to get people to understand what was going wrong in these cases. And she came up with the idea of an intersection. So here on the left, you have two separate roads that are parallel and thus will never meet. You have race discrimination in one lane and sex discrimination in another. And so she said, but of course, in human life, these roads do meet. And so she came up with the idea of an intersection where race and sex meet in this case. And of course, in life, there are many intersections. And she had a couple of really important insights about intersectionality. And the first of them was that where categories involving groups that have historically been disadvantaged overlap, we actually see injustice compound. So instead of there being sort of no injustice, as the courts found, at least under the categories of law and race and sex discrimination in the legal system, There's actually compounded or stronger injustice where identities intersect. And the second insight she came up with is that people at the intersection are often rendered invisible. And so one way in which she illustrated this many, many years later in 2016 in a TED Talk called The Urgency of Intersectionality was to ask everyone in the audience to stand up. And then she began and asked them to sit down when they recognized a name that she named. And she began to name people like Eric Gardner and George Floyd and Tamir Rice and Michael Brown. And a lot of people in the audience sat down. Most people had heard those names. But then she asked everyone to stand up again, and she started naming the names of Black women who had died in interactions with the police. Now, this was in 2016, so it was before the Breonna Taylor case and shooting and before the Say Her Name campaign. But she began to name names like Eleanor Bumpers. And basically, at the end of coming up with these names, almost everyone in the audience was still standing. Nobody recognized Black women, although they did recognize the experience of Black men who had died at the hands of the police. And so this was her way of showing that at the intersection, when something is not necessarily what we anticipate of identities, some people are made invisible. And she came up with another insight, which is basically when we focus on one category, like race, we tend to create sort of a universal experience for everyone in that category. And this universal is often based on stereotype. It often relies on images and stories that we've heard. So for example, there have been very familiar in the US, very biased media-based presentations of Black men associating them with crime in this country. And so people had a way to understand how Black men might be interacting with the police, but they didn't have the same way of seeing the experience of Black women. So because Black women didn't fit into the stereotype of what was imagined in that context as a sort of a racial bias, they were basically made invisible. Their experiences just simply did not exist. And so that's why intersectionality is really important, because people who fall outside of the familiar prisms are made invisible. So how does all of this apply to pain? Well, research and public policy on pain tend to focus on these unitary categories. They tend to see people as sort of representations of a discrete group. And we often have stereotypes about what pain is going to look like in these groups. So if we don't consider the intersection, we lose an awful lot of people. Here's an example. There's a lot of racial bias in pain care, lots of studies showing that. And we know, as Tamara will talk about more in a minute, that older people experience more pain. And yet until very recently, there's been almost no research on pain in aging Black men, because they just didn't fit into the prism that we imagined. We're imagining Black women's experience of pain when we're talking about the pain experience in race. So just quickly to sum up, before I turn it over to our esteemed panelists, intersectionality is important for health equity for a variety of reasons. The first is basically the common sense appeal, because people are constituted that way. People come at the intersection of many identities. The second is that it gets us out of a purely biomedical way of looking at the problem of pain and people's experiences. I mean, there is a long and pernicious history of race medicine in this country in which people see, and providers are not immune from this, race as a biological instead of a social construct. It is not. If the Human Genome Project prove anything, it's not. And so it gets us out of that purely biomedical way of looking at pain and people with pain. But it also helps us avoid sort of blaming and culture blaming, because we start to see people as a whole person. And there is sort of often this problem in some of these biases that where, for example, someone will be blamed for their condition because of the diet of their culture. But most importantly, I think it's useful in seeing structures and power relationships and how they really influence people's health outcomes, because it comes from a social justice background. It helps us interrogate the structures that are keeping some people disproportionately behind in pain care. And without further ado, if anyone wants to get in touch with me, these are my, this is where you can find me. And I want to turn it over to Tamara Baker.
Thank you, Kate. Let me share my screen. And I'm going to assume that everyone can see my screen now. Again, thank you, Kate, for setting the stage and providing a broader overview of, how we should focus on pain. As you can see from the title of the presentation, I'm really going to take a deeper dive into looking at disparities and also pain equity of pain care. But also I want to get into changing the narrative and how we have this discussion around pain care and pain equity. So I wanted to start off with this particular slide. No, this isn't to show the really bad 80s haircuts or anything like that, but I really wanted to show that pain is not just focusing on one person. So for example, you have someone in your family that's experiencing pain, but it really involves everyone. It involves the caregiver, which is one of the main reasons why I wanted to show this picture. My mother was diagnosed with rheumatoid arthritis when she was in her 30s, and I saw the impact that it had on my family. Unfortunately, she's passed about 16 years ago, but we still have the impact of the loss, but then recognizing everything that she went through as a result of being in the healthcare system, the many doctor's visits and many doctor's appointments. So again, this is a collective effort. Although the person, him or herself, is experiencing pain, it has a significant impact not only on the family, but the community as well. So this really led me to where I am today and having the discussion around equity and the barriers around pain care. And it really had me question why, okay? So with these 6 questions I have, what are the key initiatives addressing pain disparities and inequities? What are some of the challenges and barriers to addressing inequities? But more importantly, how do we achieve equitable pain care? And Kate sort of started that discussion around that. And then with my own specialty, how do we address pain and aging? And are we an ageist society? And I'll let you know the answer to that right now is that yes, we are. And then how do we intersectionality and understanding the pain experience? And really, Kate took us on a broad overview of that. And then the last question is why? And the reason why I asked this very simple question is because why even in 2024, we still have to have the conversations around pain equity and issues around pain disparities. So this is a very busy picture, but I really want you to focus on the arrow and also the red circle. So when I first saw this picture, it took me a while to dissect everything that was going on. But what I really appreciated about this particular slide or this particular figure is that it's all encompassing in someone in pain and what they have to go through. So again, you can see at the very top, I have outlined in the red circle, this is the pain patient. And what's really interesting about this particular figure is that the pain patient is almost seen like a superhero. You know, you have that, like the Shazam lightning bolt on the person's chest. And you can see that the person is juggling multiple balls in the air: mental health, work and day experiences and tasks, family and friends, financial burden, quality of life. But then when you really take a deeper dive and start to read and look at each part of this slide, this is really defining the pain of an individual, the life of an individual, from the provider to the family, all the way down at the bottom, which sort of relates to that first slide that I showed you with my family and how it impacted us. But also, you focus on stigmas and barriers. And then you have the pain patient again as a superhero climbing to look for coverage, defining the relationship between the provider, not being able to find a provider, having providers that opt out of the system and caring for pain patients. So again, although there's a lot going on, this is sort of a brief snippet in the life of someone that is experiencing pain and all that goes into their day-to-day experiences, which goes back to the initial questions that I asked on my slides. So again, as Kate mentioned, you know, when we talk about pain and pain management and equitable care, we know that access to pain management is a human right. So no one, regardless of who the individual is, should not receive adequate pain care. And I'm going to get into that in just a few more slides. But I thought this article really hit home to what all of us have talked about with Kate's presentation and what Monica Asmina will be talking about a little later. Over the overall purpose of this panel discussion is having access to pain care is a human right. So regardless of who you are, you should have that right to receiving adequate pain care. And again, that's really important. Now, with this particular slide, I'm not going to read everything, but I really want to draw your attention to the words and the content and the text that's underlined in red. So the problem is that a significant problem facing vulnerable population arises from conscious and unconscious biases and negative attitudes, beliefs, perceptions, and misconceptions about higher risk population groups or about pain itself. And I really wanted to focus on this because oftentimes when we think about pain inequities and disparities in pain care, it's almost like we have this linear thinking that we're only focusing on race and ethnicity or nationality. But you can see from this particular slide, there's so many characteristics and how we define disparities or inequities in pain care. It could be based on someone's sex or gender, the person's abilities, of course, ethnicity and race. And there's so many other identifying characteristics, even geographic location. We know that individuals in rural areas do not have access to the same care as someone in more suburban area. So again, I want us to stop the linear thinking and have a more broad and lateral thinking as we continue the discussion around pain care and to pain care. And again, we want to make sure that we dispute the biases, we dispute all the inequities or the stigma that goes along with receiving adequate pain care. So that's one of the main reasons why I wanted to show this particular slide, because it really hits home to how we need to continue our thinking or even start our thinking around pain care and receiving equitable pain care. So as mentioned, I am trained as a gerontologist, and my work really focuses on looking at pain management and pain care in older adults from diverse race and ethnic populations. And the reason why I wanted to show this particular slide, because we see that as we read in this particular slide, that there's a demographic shift. Basically, the number of adults over 65 years of age is going to eventually outnumber younger populations. So what does that mean for our healthcare system? What does that mean for our specialty pain care? That means that we need individuals that are specifically trained to work with older adults. We need to develop a workforce that is trained to work with these older adults. But more importantly, we need to develop and train the next generation to diversify our workforce as well. So that's one of the main reasons why I wanted to show this particular slide, because again, we know that older adults are more likely to experience pain. And if we don't have the workforce to address their needs, there's going to be a problem. So this particular slide also re-emphasizes the number of older adults that are experiencing pain. So we can see that those over 65 years of age, chronic pain is at 30.8%, and high impact chronic pain is at 11.8%. And we can see compared to these other age groups, this number is astronomical. And again, we definitely need to have a representative workforce that is going to be able to address the needs of this aging population. And once again, I like to show lots of graphics and figures and a repeat of the content just to remind this group that, again, older adults are at a higher risk of experiencing chronic pain for a number of reasons. And as we can see that as we become older, we become more vulnerable to injury, and also we have higher rates of surgery among older adults. So again, this re-emphasizes the need for a diverse workforce, but also to make sure the individuals are properly trained to work with this particular group. So with this particular slide, Kate already addressed the many definitions that we see in the literature, but also in terms that we use to describe inequities around pain. And I'm not going to go into a lot of detail because, as I mentioned, Kate already provided this information. But it's very important to understand that pain or health disparity is not the same as health equality, is not the same as health equity, and is definitely not the same as intersectionality. But what I really wanted to focus on, and some of you may already know about social determinants of health. This came out of the discipline of public health, but it was used more as a global term, but it has since become very popular here in the US, because as you can see from this definition where the red arrow directs you, social determinants of health really defines who an individual is. And it's very important because it's from the biological to the social to the environmental, as you can see right here with this definition that I've provided. But what's really important to understand, and I really like using this particular figure because this really describes how we think about social determinants of health. And for example, someone comes into a doctor's office and describes that they have pain in their lower back or pain in their knee or as a result of a condition. And what the clinician sees or what the staff sees is what's at the tip of the iceberg. But what's really going on, we need to start thinking about what we don't see. And that really describes social determinants of health. So as you can see, well below the tip of the iceberg, we have different factors that define who that person is. So for example, environmental toxins, systematic bias or poverty, genetics, substance abuse, racism, discrimination. There's so many other factors that go into defining who that person is. So again, what's really important to recognize is that we need to move beyond the tip of the iceberg if we are to continue to have the discussion around inequities, or equity, I should say, around pain care and access to pain care. So I have this graphic because this really hits home when I talk about determinants of health. So again, oftentimes we try to lump everyone into one group. All chronic pain patients are the same, and we know that is not true. So you can see on the left-hand side of the screen, that is me. And the reason why I have these different size bubbles is because when we talk about determinants of health, it has a different impact on an individual's life. So the neighborhood may have a very different impact for me than it does with my 100-year-old grandmother who is to the right of the screen. And actually that picture was taken just a couple of months ago. So the education, the impact of education that has on my health is going to be very different than what my grandmother experienced. So it's really important to recognize and understand, going back to that iceberg, that individuals bring something very different to the table when it comes to experiencing and reporting chronic pain. And that's something that we need to be mindful of as individuals experiencing pain, those in the community, those who have a relative or a loved one with pain, is recognizing that we can't put pain in a box, that we have to understand the many dynamics and the factors that go into the pain experience. So I'm about to wrap this up, but I thought this was another very important figure to show you. And I really wanted to highlight the patient-related variables and also the healthcare provider-related variables. There's just so much to unpack when it comes to understanding biases and stereotypes, and also issues around disparities and equity. And it's not to say that genetic factors or the healthcare system does not have that significant impact in how we define the pain experience. But again, as I mentioned before, as with social determinants of health, there's so much that goes into defining someone who is experiencing pain, such as cultural sensitivity, patient's beliefs, coping strategies, and even with the healthcare provider, the biases or pain assessment or beliefs, or even their own experiences with chronic pain. So I want to leave you with this particular slide, and I thought that this was very important that we recognize, I call it the A's of understanding, or the 7 or 6 A's in defining the pain experience. So is it accessible? Is it affordable, acceptable, accurate, available? And there should also be awareness of what we're experiencing as we continue this discussion around the pain experience. And I'm going to leave you with this quote: "Those who have the privilege to know have the duty to act. And in that action are the seeds of knowledge." All of us collectively have a duty to recognize and understand and do something about moving the narrative forward with regards to the pain experience. And I hope panel discussions such as this and those in the future can allow us to continue this discussion and moving and changing the narrative around pain equities. And with that, I thank you for the opportunity, and I will turn it now over to Sunita.
Thank you so much, Dr. Baker. I'm just going to share my slides now. Super. So to the other end of the spectrum of age with children now. Before I do begin, I'll acknowledge that I'm delivering this session from my home, which is located on Treaty 6 territory in Canada, which is the traditional territory of the Cree, Dene, Blackfoot, Saulteaux, and Nakota Sioux and Métis Indigenous populations. And I would like to acknowledge their footsteps that have marked these lands for generations. We share this, Canadians, when we present, share this as an act of truth and reconciliation for the injuries that have been caused through colonialization of Canada. So I want to acknowledge that as I move forward. My disclosures include honoraria from Pain, British Columbia, and the Canadian Association of Emergency Physicians, which are both knowledge-sharing organizations. I am on the advisory board for NPAC, as you heard from Kate earlier, and the science and policy advisor for them, as well as an advisory council member for opioids in our youth, which is an academic advisory board that I'm a part of through Calgary. And I do have some local and national held grants, which are peer reviewed and non-industry sponsored. I like to start with a take-home message, because I know three presentations in, even though they are been incredibly interesting and to the point, we can sometimes get a little bit lost in the slides. So the take-home messages for the portion that I'm going to speak to about children is that untreated pain in childhood has consequences, and that children are not exempt from inequity or intersectionality considerations. So a little bit of background, knowing that most presentations of spondylitis do occur in adulthood. There are juvenile versions, which I imagine you are all familiar with, that can present in younger age as well, and that 1 in 5 children overall have chronic pain. In our children who are hospitalized, they have an average of 6 painful procedures every 24 hours, and this goes up to 12 to 14 in the intensive care setting. And this kind of pain negatively impacts children's lives, including their physical, emotional, social well-being. It affects their sleep and their family lives, their ability to go to school. And we know that that's what kids do. They go to school, they eat, they sleep, and they play. And if those things are affected, it affects their long-term development. We also know that equity-seeking populations are disproportionately impacted due to racism, oppression, and adverse childhood experiences. So these are populations that we're looking to do better for every day. So what happens if we have untreated or undertreated pain in childhood? Why does this matter? Does it toughen up our kids? Does it make them more able to deal with pain as adults? The short answer is no. I'm not talking about playing at the playground, falling while you're running in the sand, looking up, seeing your mom, and then deciding whether it's worth crying or not. That is a part of childhood, and those are the decisions children make every day. What I'm talking about is chronic pain and painful medical procedures. That's not a part of typical childhood. Those are things that we have capacity and ability to do better for. So in the short term, when we have a child with untreated pain, they have trauma and suffering and lower satisfaction with their healthcare experiences and frankly, their life experiences. In the longer term, these children go on to develop increased sensitivity to pain, increased likelihood of needle phobia, healthcare avoidance, where they no longer trust their body's cues, so they avoid coming into the hospital, and it actually affects brain development and IQ. So when we have untreated pain in infancy and early childhood, these children go on to have documented lower IQs and effects on their brain development. The operational implications within our healthcare system is prolonged hospitalization, more procedure attempts, increased length of stay for emergency or clinic visits, and more postoperative complications. When our body is stressed by pain, it doesn't relax to heal in the same way it does when pain is treated well. Here's the kicker for children. 80% of the therapies we use are not tested in children. And this includes, and it's probably higher for analgesia. So for pain medications, only about 20% of the medications are tested through the FDA or in Canada through Health Canada before they're used. So the vast majority of drugs we use in children are off-label. And so this asks us then, begs the question, can we do better for our children? They are our future. Can we not do better to make sure the treatments we use for them are safer? And when we're testing them to decide if they're safe to use in children, can we use an intersectional lens to consider all the children who might have these conditions, not just the communities that are more convenient to study? So I know we've talked about this already, but this is just a reminder to myself and to you that children are not exempt from intersectional considerations when we're considering their pain care. They bring their own story, they bring their own sociodemographics, and then they are embedded within a family, and their parents and their caregivers and their siblings' decisions and life circumstances also influence their lives. So I'm going to take a few moments in the next 4 to 5 slides to go through specific intersectional considerations. So let's talk about age first. So we are ageist, just as Dr. Baker told us. We're also ageist against the youngest of our children as well. When we compare children to adults, they get less analgesia and they get less appropriate opioid analgesia for severe pain compared to adults. Not only that, but when we look within children, The younger you are, the less likely you are to get appropriate pain medication. So to give you an example, they looked at children, a research study looked at children with significant fractures and burns, like big bone fractures and burns. And if you were under 2 years of age, your chances of getting no analgesia, so like no pain medication, was 65% compared to under 50% if you were school age. And then similarly, to get appropriate medication for burns as well was 50 versus 25%. So 50% if you're school age, 25% if you were under the age of 2. So even within children, we don't treat their pain the same way. When we look at gender and children's pain, there's a lot of stereotypes about how boys and girls may bias that may react to pain and how that biases our pain assessment. And then different conditions and different locations of pain can influence whether boys or girls receive more treatment or less treatment. And this is not even considering the full spectrum of gender identity. This particular study that I want to tell you about actually looked at over 500 people who were asked to look at videos of children having a painful procedure. They were getting a blood test on their finger. And when the children presented and were given boy names, their pain was rated, they were rated as experiencing more pain than when that child was presented as a girl and had she, her pronouns used. They assessed the pain as being less significant. And so they showed that as a society within this group of 500 plus people, and by the way, this was a enactment of a prior study. So they were updating it, hoping that the results would be better in modern times, didn't show up. When we think a boy is in pain and when we see a girl in pain, we perceive the boy's pain as more significant. And to control for this, they actually took the same story, same video, but used a more gender neutral presentation. So in terms of how the child looked on the screen, and changed the pronouns, and the effect went away. So it has something to do with how we perceive people when we think they're boys and when we think they're girls. And this kind of feeds into this idea that boys are these stereotypes that boys are more stoic. So if they're expressing pain, it must be more real than girls, which is of course not the case. Talk a little bit about pain and disability and ability, different abilities in children. Children with different who are differently able have their pain under-assessed and undertreated. There's no question about that. What's really unfortunate is that the children who have profound intellectual or multiple disabilities are actually at higher risk for having more painful conditions. So these are the children you might see who are developing pressure ulcers from being in a wheelchair chronically. These are the children who might have feeding tubes, and so they can get infections around the tube, or the tube can migrate. And their assessment of pain is universally rated by healthcare professionals as harder to do. And these same 100% of healthcare professionals surveyed said that they find it harder to measure pain in children with disabilities or intellectual difficulties. Almost 70% of them, or over 70% of them, in fact, said that they truly believe that these kids were under prescribed pain medication because they weren't doing a good enough job measuring their pain. So these children are at higher risk to have pain. We're worse at measuring it, and when we do measure it, we undertreat it. What about race and children's pain? Surely we must protect our children from this, right? Despite our best intentions and efforts, this still profoundly affects children. Black and Hispanic children are less likely to receive analgesia than white children, and Black children are less likely to receive opioid analgesia for severe pain than white children. And these numbers are not subtle. When we look at something like appendicitis, so appendicitis is a surgical condition, your appendix is swollen, it needs to be removed. It almost universally gives moderate to severe pain in children. When they looked at children who were black versus white, the Black children had a 90% decreased odds of receiving analgesia compared to white children, or an odds ratio of 0.1. And when we looked at them receiving opioids for the severe pain, and this would be an appropriate use of opioids, it was 80% lower odds of receiving it than white children. So, and this study has been redone with multiple conditions, looking at groups of 1 million children or more in the US, and the results are consistent. As I did introduce myself as a Canadian, I want to be clear that I'm not trying to be holier than thou in any way. We have the exact same problems in Canada. And in fact, I would unfortunately say that in Canada, we're further behind because we don't document and measure it in the same way that the US does. So in the US, you are ahead in that you can discuss it because you have the numbers to back it up. We are just learning to start tracking our information in a way that allows us to interpret it. So these are 2 adults, but these were both Indigenous individuals who suffered greatly at the hands of our healthcare system, and both did die. And it was deemed fairly clear that their being Indigenous was a contributing factor to their death. So what can we do for our children? Well, we can build into our healthcare systems and our governmental policies the right to equitable and accessible healthcare. And one of the first steps we took in Canada last year that I am wildly proud of is the world's first health standard related to pediatric pain management. So Canada created the world's first standard that is that now asks healthcare institutions to be judged against the standard at accreditation time to determine if the way they are treating pain for children is adequate and equitable. At this time, because it is a brand new standard, it is an optional standard against which you can be judged. But the goal is in the coming years is that this will become a mandatory standard. So through that standard, what we're able to do then is encourage all healthcare facilities that treat children to have similar standards and similar services available to all children. I do encourage you, if you're interested, if you just search HSO pain standard, you can download a copy of it or the executive report for free. I wanted to touch briefly, I am a pain researcher as well, about intersectionality and research. When we do research, we have to ask families to join us in research, to please participate. Sometimes there might be a nominal reimbursement or a gift, but really it is their time that is being volunteered. And in the past, we've gone to the families that are most likely to say yes. We might ask everybody, but the families that are most likely to say yes come from more advantaged situations. They tend to be affluent, they tend to be highly educated, and they tend to have, they tend to belong to a white race. So what I ask is that we, moving forward, we welcome participation from all, and we facilitate it. So we have now all this incredible technology with phones and tablets. We can use translators to help families that aren't speaking English, that do not speak English as a first language, to help them participate in research. We make a point of collecting relevant demographic characteristics. Even if we're not entirely sure what to do with them right off the bat, there are people who are experts in this who can help us so that we can better understand when we're, for instance, doing a clinical trial looking at a pain medication for children, if it works for a particular subgroup of children and doesn't work for another, versus having 75% of our participants be white children and then say it works or doesn't work for everyone. Maybe we can start actually breaking that down. Maybe if we look at sex, for instance, female react differently to a pain medication than males, but we won't pick that up if we don't actually do that sub-analysis to try to look at that. We should start integrating the social determinants of health into our modeling. So when we're looking at if a medication works, don't just look at age, sex, and disease process, but actually start factoring in the social determinants of health that Dr. Baker and Kate were telling us about earlier, to help us understand how our social circumstances, social conditions influence our capacity to respond to pain, and broaden the lens of interpretation. So try to look at it more broadly for our whole population, and not just subgroups of it. I also practice in a children's hospital in an emergency department, and I think we need to think about intersectionality when we're treating children's pain in the department, in the emergency department or in the hospital as well. we need to check our biases. We all have them. None of us are exempt to them. And if we think about it, it can help us be more equitable in the lens we use when we're treating the patients in front of us. Consider again those social determinants of health. And I know in the US, I think you are generally, I have family that lives in the US and I've seen the healthcare interactions there. I think you are far more ahead of Canada in terms of considering the social determinants of health when prescribing medications, for instance, and considering health insurance coverage, these kind of things. I don't think we're as good at that in Canada, where we assume since we have socialized medicine, everyone will have access to the same care and drugs, but that's not always the case. Not everything is covered by medical insurance. Respect that life experiences influence pain, and that the expression of pain and the extent to which it will disable someone will be different, and will be highly influenced by their life experiences. Listen to your patients. I know I'm not saying anything that probably the people on this call, on this meeting today don't already know, but I think it's really important to hear their story and how the pain is affecting them, and not impose our lens of how we would experience the same injury or illness. And this is the last question is the one that I ask myself more and more every shift, is I ask myself if my management would look different if the patient in front of me looked different. And that different might be color of skin, it might be language, it might be whether they walked in or used a wheelchair, it doesn't matter. But would I be different if they look different? So I'll end there with someone that is probably close to Dr. Baker's heart, and that is Maggie Kuhn. And I think this is a reminder for me that we need to speak our mind. So if any of you are not familiar with Maggie, she fought against ageism and in the workforce against the mandatory retirement at age 65. And judging by how much spunk she has in that picture, I suspect she had a lot of years to give after her 65th birthday to whatever she was doing. But this slide reminds me that we have to always speak out, even when it feels uncomfortable, even when it makes us feel vulnerable, if it is for the better of others. I'll end there with this thought that this work that we're doing as a community, patients, families, healthcare providers, lawmakers, advocates, this is a marathon, not a sprint. So while some days it may not feel like we are making headway, every step forward is a step in the right direction. Thanks so much, and happy to take any questions. I will hand it over to my colleague, Dr. Malamapalli now.
Thanks, Dr. Ali. I'm going to get my presentation up. All right, good afternoon, everyone. My name is Monica Malampalli. I'm the president and founder of the Institute for Women's Health Strategies. I'm also the executive director of a nonprofit advocacy organization called Alliance of Sleep Apnea Partners. And as Kate mentioned before, I also serve on NPAC's Science and Policy Advisory Council. A bit of my background, I'm actually a trained biomedical scientist, but have been focused on women's health, advocating for women's health and women's health research for the past 15 years. So what I'm going to share today is some of the some of the background work that I have done in advancing, the conversation around women's health, but also, speak about in my experiences, again, taking the sex and gender lens and applying that to, chronic pain. Some of the key concepts I'm going to go over today is, again, the intersectionality and health equity, but taking it, looking at it for more on the individual level. A lot of the conversation and chronic pain in the past has been more on the public health level. So this is just a different approach that I'm going to do today. Also then applying the sex and gender lens to chronic pain, and then talk about some of the disparities there. Then I also will touch upon chronic pain and its connection to mental and sleep health. Cannot help addressing sleep here. I think this is not talked about enough. And then finally, propose some strategies and solutions in advancing and advocating for chronic pain care management. So you've heard the definitions from the speakers before. Health equity is when everyone has the opportunity to be as healthy as possible, but we can only achieve health equity when we also understand what are the disparities that exist, that is the differences in health outcomes and the causes among different groups of people. So if we apply the intersectionality and equity at an individual level, and here I've chosen 4 variables: the sex, gender, age, and race, and this is what I'm going to actually focus on. And as again, Kate mentioned, sex and gender are 2 very different terms. Often they are interchangeable. And so I'm going to go through defining those 2 terminologies. But before then, coming to disparities, this is a cartoon from 1991 that says a doctor telling his patient, a woman, saying that we have studies of fruit flies, mice, hamsters, frog, monkeys, and men with this condition, but medical research using women as subjects just never occurred to anybody. And this is true because it's only been 30 years since women were included in biomedical research. And that changed after the 1993 NIH Revitalization Act, requiring federally funded research to include women in biomedical research. So what does that mean? That meant that any data that was generated in research was generated on men, a white male, 75 kilo, and that was being just applied to everybody. So we made progress in the last 30 years, but we still have ways to go. So I want to talk about these 2 terms, sex and gender. They are not the same. So sex is more often used in scientific sort of context. It's a biological variable, and it's based off of basically, it's defined as male or female, and it's according to the internal reproductive organs and the functions that are assigned by the chromosomal complement. Gender is actually a social construct. That's a person, how they represent themselves as man, woman, masculine, feminine, both or neither, and a person's response by the social institutions. There's a lot of confusion between the 2 terms, and science has not done a great job with it too, because during a few years ago, about 30, 40 years ago, again, even in the scientific literature, both of these terms were being interchanged. When both of these, for majority of people, sex and gender are aligned, but when they're not aligned, those people refer themselves to as trans or non-binary. So again, it's very important to understand these 2 terms, because even when we collect a lot of data as a scientist, it's important for us to be able to analyze data by these 2 variables, male and female, because a lot of the biological, physiological processes in the body are impacted by the chromosomes, or again, or the hormones within the body. So it's very important to understand these 2 terms. Tamara showed this slide earlier, and again, I wanted to point out the disparities. This is data that came out of the CDC and shows the disparities in chronic pain prevalence. And on the left is they actually broke down the data by men versus women, and you'll actually see 21.7% of women are impacted by chronic pain, and it's also high in high impact pain, which is again a pain that affects a person's function or ability to function due to the pain. And again, women are more impacted by this pain. And again, Tamara shared this before. You will see that as there's an increase in age, 65 and older are more affected by chronic pain as well as the high impact pain. But then you look at the race demographics and you will see that it's mostly Caucasians who seem to be more impacted by chronic pain. If you're looking at this data, what is missing here is, again, like Kate pointed out, the unitary approach. We want to see the breakdown age by sex or sex by age. So you want to see this breakdown of this by men versus women, right? Because you want to understand who has really been impacted by this. This says it's women, but then we don't know, is it more white women, Black women? We don't know. And same thing, again, sex by race. So we need this data, again, stratified by race as well as age. And we don't see that often. All right. I just wanted to put this quote up by Dr. Carmen Green, who actually said the unequal burden and the unheard voices of women, particularly women of color, are, I believe, one of the most pressing needs in pain research. And I would also say it's just not the pain research, it actually applies even broadly to other areas of health and just not pain. Almost 70% of painful disorders actually occur in women. This is a paper from 1997, which actually showed a female prevalence in all of these conditions. Spondylitis actually has more of a male prevalence. And again, these are some of the other conditions that did not have, basically had no sex prevalence. So again, talking about sex and gender differences and chronic pain, just want to pull this one, I won't say code, but from this paper that says women compared to men received less effective pain relief, less pain medication with opioids and more antidepressant, and got more mental health referrals. That just shows us the state of chronic pain care in women currently. And there are a lot of papers published in sex and gender differences in chronic pain. But again, women tend to receive less care compared to men. If you also look at the painful conditions, so chronic pain, there are many comorbid pain conditions so in here, there are only few that have been taken into consideration for this slide. And as you see, the pink refers to chronic pain conditions in women, and the blue refers to the pain conditions in men. So as you continue to see more chronic pain conditions, you start to see a greater difference between men and women. So 4+ more conditions, you see more of these pain conditions in women compared to men. And this is something, again, we need to take into consideration when a woman goes in for her care, is even trying to understand what other pain conditions that she has. If she's coming in with migraine, I think it's important for the providers to ask what other painful conditions that she might be having, because again, you have to take that into consideration when you're trying to treat a patient. This is, again, a paragraph that I picked out of the Pain Management Best Practices Task Force report. We were very happy to see that this was acknowledged, or women in pain and sex differences was acknowledged in this report. So what was mentioned was central to the unique issues women face in pain management are differences between men and women with respect to pain sensitivity, response to pain medication, and predisposition to clinical pain conditions. So at least it was acknowledged, but again, a lot of work still remains in this area. I'm going to shift a little bit of the gear here and talk about the biopsychosocial model of pain. Pain is very complex, and it was recognized many years ago that there are 3 domains that we need to acknowledge in understanding chronic pain. One domain is the biological domain, where you have the hormonal factors or the response to treatments, which again might interact with the social domain, which can refer to stigma, again, cultural differences, relational demand. And then you have the psychological domain, which again can speak to stigma, depression, PTSD, trauma, etc. All these 3 domains. So in trying to understand the chronic pain, you have to consider all these 3 domains, because one domain may influence the other domain. We're yet to know all the variables that fall under each of this domain, and we still need to understand how each of these variables interact with one another. So again, there is some research in this area, but again, we definitely need to understand this more. And it just made me think, and trying to, think about the intersectionality and the equity stuff, trying to see, okay, the sex is a biological variable. It fits under the biological domain. The gender and race may fit under the social domain. And then the age, more on the psychological. So I think having this framework and taking to some of these variables that even Tamara has mentioned in trying to probably put under some of these domains and trying to simplify and see how we may be able to address chronic pain care when it comes to both women and men. This is just an example. I apologize for a lot of information on this text, but this was a quiz that I've asked before. So if you have, and this is something what Tamara shared too, if you have two middle-aged women of the same age with similar degrees, say of moderate arthritis, coming with two different socioeconomic background and support, do they report similar pain experiences? And the answer is false. That means they have two different experiences when it comes to pain. So one woman may have a strong family support and a different socioeconomic background, and the other woman may be single with few friends, lower socioeconomic background, and may report actually more severe pain compared to the first woman. So again, in this case, the one domain of biopsychosocial framework is influencing the other factors in this domain. All right, so again, shifting the gears again a bit, talking about chronic pain, sleep, and depression. So this adds to a little more of the complexity, right? So here I'm talking just within the context of chronic pain, sex, and gender differences, and mentioned briefly the race and age, but now I'm broadening this up a bit and saying, how does then chronic pain relate to these two other areas of sleep and depression? Again, there's plenty of literature and science suggesting chronic pain is, again, connected to depression. We know that. We know that depression, again, has this bidirectional relationship with sleep disturbances, but we are yet to understand what the precise relationship is. We also know that pain and sleep disturbances have this bidirectional relationship. So if there is pain, you have sleep disturbances. If you have sleep disturbances, that increases the pain sensitivity. But again, this is another call out to researchers to understand what is, again, the precise relationship, so we can then predict better response to chronic pain treatment and management of patients. Here, I actually tried to, like I mentioned earlier, that it's mostly females who have, majority of the painful conditions. But I just, again, wanted to show that we don't have great data. I mean, this is some, recent, again, data that comes to prevalence, but it is showing some connection to depression and anxiety. So about, you see, again, it's more common in, the prevalence is higher in males. And somewhere around, I think, 17 to 43% is what we see depression. So definitely depression and anxiety are common comorbid condition when it comes to spondylitis. But it's the same when you look at other pain conditions that are also prevalent in women. When it comes to sleep and pain connection, they're, again, very highly morbid. There are many articles out there suggesting, the connection. Interestingly, when you look at pain disorders and chronic pain, it's more common in women compared to men. And I would bet if you look at the sleep disorder, the number one disorder that women tend to complain is really insomnia. And which, again, makes it worse when it comes to the chronic pain. Sleep loss will increase pain sensitivity, and again, is a major risk factor for also developing chronic pain in women. And I did a little more digging into looking at spondylitis, and it showed that there was a high and significant prevalence of sleep disorders. At least 53% of the patients with spondylitis had sleep disorders. There was this other paper that I found, and I was very curious about sleep apnea. Sleep apnea is spelled differently here because this is more of a European spelling. It's spelled differently here in the United States, doesn't have the O. But what this paper showed is that, and this was a recent paper published in 2022, showed that patients with spondylitis did not have a higher prevalence of obstructive sleep apnea, but there was only a difference when these patients were older and also had a higher BMI versus patients that had no obstructive sleep apnea. Also, patients with spondylitis and OSA had lesser chest compression versus patients without obstructive sleep apnea. So they're finding some differences, some connections, but again, there was not much of a literature here. And by the way, sleep apnea is one of the most common sleep disorders out there. So moving forward, how do we optimize for chronic pain care? And if we try to apply sex and gender, one thing I do want to make it clear, when we talk about sex and gender lens, we are not saying, it applies to both men and women. We're simply pointing out the biological differences and other factors that relate to that, but we're also talking about care for both men and women. So we have to start thinking about how do we engage patients if we want to have, want to see some change here. And also, what changes do we want to see in the clinical care? In the end, we want to make sure that the policies or the systems change that we see benefit, again, both men and women. So for patient engagement, what can patients do? So what are one or two things that make your pain better? Can you ask your provider about the biopsychosocial approach to care and question them and their understanding, maybe encourage them to understand this approach so that they can help treat your pain better? And then how do you plan to communicate and engage with providers? Similarly, when it comes to healthcare providers, what can the providers do? Again, can you start to adopt biopsychosocial approach to care? Maybe spend a little more time with your patients, understanding what their mental health and assess their mental and sleep health. Often, providers don't ask about the sleep health in their patients. Perhaps that's something you can talk to them and see if one, they have a sleep disorder or their sleep is, disrupted. Maybe that's making their pain worse. And again, take trauma into consideration, because I think that definitely impacts, chronic pain. And so perhaps you can practice trauma-informed care in treating your patients. And finally, systems change. What can policymakers and system administrators do, right? Is there a particular policy practice that is disadvantageous to women? Maybe you want to examine that. Again, taking the biopsychosocial approach, can you identify what barriers are prominent in your system and hospital and try and change those? And how can you make your organization make pain care more equitable? So these are just some thought-provoking questions that what each individual can do within their environment to overcome some of the barriers. I'm going to end here, but again, in working towards achieving health equity in chronic pain health, what is one thing that you're willing to do? Because again, we can even if we just do one thing, we're at least moving in the right direction. So again, thank you for this. If you have any questions, please, happy to answer. And also you're welcome to email me at monica@mmiwhs.com.
All right, thank you so much for that insight. Unfortunately, we did lose Dr. Baker due to a conflict in time. But if there are any additional questions, please feel free to submit them now. If there are any related to Dr. Baker's Q&A, please also feel free to submit those, and we will try to get them answered via email following the presentation. So as we're waiting to see if questions come in, I am kind of curious in regards to the study that was mentioned. How much time are you aware that had passed between the initial study that was done regarding stereotypes and pain for boys versus girls? Is there any additional information on that?
I assume that's for the study that I mentioned. I can take a very quick look while we're addressing perhaps the question in the chat, and I can absolutely pop back on with the answer. I don't want to misrepresent, but I will quickly check that and let you know right away.
Okay, perfect. And we'll start taking some of the other questions here. Okay. Thank you all. I'm so glad the topic was covered. I'm wondering what support is out there for trans and non-binary folks who may not be supported by their own communities.
I would like to at least interject in and first of all, confirm that there are also, lots of studies that show significant disparities and inequities when it comes to trans and non-binary people in terms of pain. That is certainly something that is being studied more, and that where we see more barriers to care, some studies suggesting greater severity of pain. In terms of resources, I know that some of the groups that support LGBTQIA rights have been good about access to care in general, but I'm not specifically aware. I'm wondering if others are. And Carice, who asked this question, may even have some resources that they can offer for where people can turn specifically in regard to pain care.
Thank you so much, Kate. Another question, how can we better communicate to our care providers if we find we are being not looked at holistically and fit into one of these categories?
I can take that question. I think, like I pointed out, I think it's important to understand and share with your background with your provider and letting them know where you're coming from. And I think providers just, again, don't ask those questions. And try and probably point them in that direction in identifying that what is making your, pain worse. So, and something that I, again, showed in my slides earlier, definitely, I think, self-advocacy is so important for patients to be able to have the conversation, make it clear. Providers sometimes have very little time, but how can you be really effective in getting your message across and sharing with them broadly what you're going through and looking for? So again, approach them, talk about the biopsychosocial model, make them aware of that and say that you've heard about this and this is how, make them understand pain is complex and how are they able to treat you, understanding, the complexity of the pain and where you're coming from.
Great, thank you.
If I may jump in, I just found the response to that prior question. So the one that I presented with the 500 children, the recent study was published 2019. And the one prior to that they were recreating was done in the early 2010s, published in 2014. So these are both studies that are in the last essentially decade.
Great, thank you so much. We do.
I would also add that to Tyra's question, just from a policy point of view, I think it's interesting to note that there is a real move in the public health arena in the United States to start looking at pain care through what they call a whole person lens. So really looking at people holistically and considering all of these aspects of care. At least that is starting to enter the conversation at NIH and FDA and CDC and other places, and CMS as well, Center for Medicare and Medicaid Studies.
Great, thank you so much. And if you have any other questions in terms of resources and educational materials that we have, you can also email us at info@spondylitis.org. So on behalf of all of us at SAA and our presenting partner, Impact National Pain Advocacy Center, I'd like to thank our panel for their expertise, their passion, and their dedication, and all of you as attendees for your willingness to join us in advancing this conversation on health equity. So a follow-up email will be sent regarding today's presentation, as well as information on how to stay connected with the organizations that you expressed interest in hearing more from during the registration process. Thank you all and have a good day.